So good morning, good afternoon, and welcome to everybody who's connecting to the PAHO webinar on rapid mobile phone surveys on NCD policies. We're just going to wait one more minute because I see people are still entering the room. Muy bienvenidos y bienvenidas a este webinario de la OPS sobre encuestas móviles.
Welcome to this webinar of PAHO on rapid mobile phone surveys on non-communicable diseases, and we'll wait just a few minutes to give other people the chance to connect. Good day, and thank you for connecting on time.
Carolina, no sé si tienes la primera lámina que muestra. ¿No? Gracias. Gracias. So let's get started. Welcome again to the PAHO webinar on rapid mobile phone surveys on NCD policies. We're really excited to welcome you to this launch of this new PAHO tool. I'm Silvana Luciani. I'm the Unit Chief for Non-Communicable Diseases, Violence and Injury Prevention at the Pan American Health Organization. And I bring greetings from Washington, D.C., our headquarters, and welcome you all for what promises to be a really exciting session where we're going to launch the Rapid Mobile Phone Survey on NCD policies, which is PAHO's new approach and new tool that is being used to measure NCD policies and interventions at the population level and as a complement to other existing NCD surveillance tools, such as step surveys. Before we get started, just to review a little bit of I know by now after 2.5 years of Zooms, everybody's used to it, but just to review some of the logistics. This is a webinar in 3 languages, English, Spanish, and Portuguese, and we have simultaneous translation. And to access it, you click on the icon that's at the bottom, the little globe that says interpretation, and you just click the language that you prefer, English, Portuguese, or Spanish. Also, we want this to be really interactive. A lot of us are going to be talking, but we really want to hear from you. There's 171 people connected right now. We want to make this as interactive as possible. So please write in the chat, the little chat icon below, or write your questions and answers in the Q&A icon below at the bottom. So let's make this as interactive as possible. Again, we're really excited to launch the PAHO RaMPS survey tool and to talk a little bit about the experiences of using the rapid mobile phone surveys in our region, which has been used during the pandemic to gather timely data on COVID and the impact that COVID has had on implementation of NCD policies and interventions. So in the next hour and a half, what we're going to do is just present the tool, talk a little bit about how it's been applied in the Americas region, and hear about some of the really interesting results on how people with NCDs have been affected by the service disruptions due to COVID, among other topics, and really understand where we've been with the RaMPS tool and where we're planning to go in other countries with the RaMPS tool. And we hope that by the end of this hour and a half, we're going to really inspire you to work with us at PAHO and with our partners to adopt this innovative approach to monitor NCD policies in your country. And before we begin, I just want to say a quick thank you. Carolina, I don't know if you can just switch over to the slide, which shows all of our partners. We're really pleased that as the Pan American Health Organization works really closely with ministries of health, that we've been able to implement the RaMPS survey with the support and collaboration of ministries of health. And then we partner really closely with the Centers for Disease Control and Prevention. And so they've worked with us alongside in the implementation and design of RaMPS. And lastly, with Research Triangle Institute, RTI International has been a main partner. And none of this could have been possible without major funding support. Next slide, please. And we just want to give a shout out and a big thank you to the organizations that have helped make this possible. The Public Health Agency of Canada, the CDC, Centers for Disease Control and Prevention here in the US, and as part of the World Health Organization Universal Health Coverage Partnership, funding support for surveillance. Again, surveillance, especially on NCDs, is an underfunded and under-recognized area. So we're really pleased to be able to have the support and partnership and be able to showcase some of the great work that we've done in designing an innovative tool through RaMPS and then implementing it in some countries in the region. Next slide, please. So in the next hour and a half, I know this is a squishy slide, but in the next hour and a half, we're going to present some opening remarks to just set the scene around why we need to strengthen NCD surveillance in the region. Then we're going to move on to present the RaMPS survey, the Rapid Mobile Phone Surveys on NCD, so you can learn a little bit about how it's designed, what were some of the questions, and we're going to tweak your interest by showcasing some of the results. Then we're going to move on to talk about phone survey modes for data collection as context, also for the RaMPS survey, and also talk a little bit about how mobile phone surveys can be used beyond simply monitoring NCD policies, but also as an innovative strategy to measure socioeconomic measures. And then we'll talk about some of the experiences in countries in our region, from Brazil, from Paraguay, and then you'll learn about what our plans are to implement RaMPS in other countries in the region. So that's an overview of the next hour and a half. Please start preparing your questions as you hear the presentations. So let's begin with our first presenter, and it gives me great pleasure to welcome Dr. Anselm Hennis, who's the Department Director for Non-Communicable Diseases and Mental Health at PAHO. And he's going to give us an overview of NCD surveillance in the region and really bring home the point about the need to strengthen NCD surveillance. So over to you, Dr. Hennis.
Thank you, Silvana. Let me just try to, oh, here we are, wonderful. I unfortunately have this problem of having 3 screens with the new situation that we're working with, so I'm trying to find which screen I'm supposed to be on, so do bear with me. Good morning all, and a hearty welcome to you to this, this webinar. I'm going to put up my PowerPoint. Here we go. Here we go, I hope. Are we there, Silvana? Do you see my presentation?
I don't seem to see it.
Let's go again, sorry. Let's go again. Share screen. Here we go. Is it there now?
It's there now.
It's on the wrong slide, of course.
Yeah.
Okay, let's go back a little bit. Just give me a second. Right, it's not reversing.
Oh.
Give me a second.
Technology is great when it works.
It worked a second ago.
Yes, that's true. Murphy's Law doesn't
Okay.
work when you need
Let's
it.
go again. Okay, let's sorry about that.
It's okay. We understand the technical challenges that
No, we now have
Zoom
computer,
poses.
and then we have 2 screens. And therein lies the problem. Okay, let me close my share and start again. Give me a second.
Sure.
Good. All right. Good. So let's try again. Good. Okay.
So for those who are connecting, this is Dr. Anselm Hennis, Department Director of Non-Communicable Diseases and Mental Health at the Pan American Health Organization, who's going to present on the need to improve NCD surveillance in the region.
Okay. Sorry. Okay, let's try again. I think we're going to master it this time. Is it up now?
It is up now.
Is it in the right place?
It needs to be in presentation format is all.
Are we there now? Presentation?
Yes.
Hallelujah. Okay, sorry about that. Let's go.
Adelante.
Okay, basically, so good morning, good afternoon to all. And it's indeed a pleasure to participate in today's webinar on this initiative on surveillance, the Rapid Mobile Phone Survey. And as we have learned, this can be used during public health crises, and more importantly, it can measure practice, behavior, and attitudes in NCD policies and interventions within our populations. So with this tool, we aim to strengthen surveillance capacities in countries to produce data to accelerate and support the implementation of the evidence-based policies and interventions, which we all know as WHO NCD Best Buys. Now, it's been more than a decade since member states first committed at the United Nations General Assembly, this is back in 2011, to fight the burden of NCDs and adopted the global and regional action plans to prevent and control NCDs. With these commitments, there was also a call for countries to strengthen their surveillance capacity to report and monitor progress. While we've been focusing a lot of attention on gathering the risk factor prevalence data and the mortality data, we think there needs to be more attention based on gathering data on the NCD policies and their impact on populations. We believe that the Rapid Mobile Phone Survey adds a new tool to the surveillance toolkit, and which will close this gap. NCDs, as you know, are preventable and affect the lives of millions of people, many of whom are unable to access the care they need. And it's also linked to poverty when care is unaffordable. So one of the responses to this burden is implementation of evidence-based policies and interventions. The burden of NCDs in the region of the Americas is worrisome. And I want to share with you some fundamental facts and figures in the region of the Americas. And every year, NCDs are responsible for 5.8 million deaths in the Americas, and this represents 81% of total deaths in the region. 1/3 of these NCD deaths are premature, and that means they occur in persons aged 30 to 70 years. And the principal causes are due to cardiovascular diseases, followed by cancer, chronic respiratory diseases, as well as diabetes. And these 4 NCDs share common risk factors. As you can see in this table, region of the Americas ranks very, very highly in terms of issues such as insufficient physical activity, overweight and obesity. And in fact, we are the most overweight region of all the 6 WHO regions. We have made progress in tobacco use. There are also problems with heavy episodic drinking, but we have the second highest alcohol per capita consumption of all of the WHO regions. So really, if you're able to successfully tackle these risk factors, it not just will save lives, but also improve lives of those persons living with non-communicable diseases. When we look to progress made by the countries of the region in terms of developing plans nationally, interventions, policies, enacting legislation required to set the environments where the healthy choice is the easiest choice as presented in this table, this is the status of the progress indicators in the region. We see many, many points that are red, which indicates how far we are behind in the successful implementation of these policies and interventions. So if you really want to have an impact on the health of our population, we cannot afford the cost of inaction. We have learned a difficult lesson during the pandemic, whereby those living with NCDs were those most vulnerable to complications and mortality from COVID. We need resilient health services, and resilient health services require strong surveillance systems. That is why surveillance is an essential public health function, and that is why we need to strengthen the capacity in the region, not only to monitor the number of deaths and risk factors in the populations, but also the implementation of cost-effective policies and interventions at the population level. Having timely data is key to accelerate progress and translate commitments into action. In this scenario, RaMPS, as we know it, is an innovation that will help fill the gaps in information on NCD's policies and their impact on populations. I wish you all to participate fully, learn from the experiences shared, and leave this session motivated, but also contribute to the discussion of this session. Each of us has a contribution to make. Join us in the front lines to fight the burden of NCDs in the Americas, and look forward to continuing our partnership with you. Thank you so much.
Thank you. Thank you very much, Dr. Hennis, for setting the stage and really taking it home that we need to improve surveillance systems for NCDs. And while you showed great data on risk factors and mortality and a little bit on progress of NCD policies, I think there's much more that can be done and needs to be done. And who is going to talk more about what can be done to monitor NCD policies is our own regional advisor on surveillance, Dr. Roberta Caixeta, who's leading NCD surveillance for the Americas at the Pan American Health Organization. So Roberta, over to you to present RaMPS and all the innovative work you're doing to help fill gaps on NCD policy monitoring.
Thank you, Silvana. Thank you, Dr. Hennis, for setting the stage. So I'm really happy today to share with you this new tool that we are adding to our NCD surveillance toolbox, which is called RaMPS, Rapid Mobile Phone Survey. So our main goal with RaMPS, as we said, is to measure the practice, behavior, knowledge, and attitudes of the population related with the NCD policies and intervention. So that's what I want to share with you all today. So next, Caro, please. So a little bit of the background of why we moved towards developing this tool. First, due to the impact of the pandemic, right? In the height of the pandemics, we saw the need of having data. Countries requested support to produce data not only on to know more about their response on COVID, but also to assess how was the access to healthcare on NCDs within the population. We do have tools that allows us to understand if countries have or not have developed policies, but we were lacking a tool that would gather information on the effect of these policies, of the lack of these policies in the population. So we are adding RaMPS to fill this gap. So it's a complementary tool to what we already have. Does not replace household surveys, because as you know, we need to do measurements for some of the indicators, such as hypertension, such as overweight and obesity and diabetes, but it will give us a lot of information in terms of policies and interventions. The penetration of mobile phone survey in the region, of course, we have done a study to understand what would be the representation of the data that we collect, and it's pretty good in the region. Of course, we have exceptions in Cuba and Venezuela, for instance, but the majority of countries that we have implemented and we have been studying, the mobile phone survey penetration has increased throughout the years. So here, just to review, we think RaMPS could fill this gap, producing data at the population level on practice, attitudes, behavior, and knowledge in terms of policies and intervention, and also will be useful if we need to face any public health crisis, which we don't want to go. We hope we don't have to soon. So the target population for RaMPS is those among 18 and older with access to mobile phone surveys. Okay, next, Caro, please. So we had to make decisions about the methods for RaMPS. What would be, as you know, there are so many different methods and possibilities in the world of using phone surveys, especially during the pandemic. This type of way of data collection increased a lot, and everybody was trying to figure out how we could better have data that it's reliable, and at the same time we could get the data in a rapid way. So our decision was to use a short questionnaire. As you all know, nobody want to be on the phone responding a survey, so we choose to go a short questionnaire with mainly questions that were already standardized for COVID and used it in many countries during the pandemic. But we also have developed, as part of the initiative, a set of questions for policies and interventions related with Best Buys and NCD recommended policies and interventions. And then that's what we are aiming to use in the second phase of the project that we'll talk later on policies and interventions. The mode we choose for RaMPS is Caddy, computer-assisted telephone interviewing, where that is conducted by trained interviewers. Our sampling strategy was to use a probability sampling of mobile phone numbers, stratified by mobile network operator. For some countries like Bolivia, we were able to stratify also by geographic areas. we do allocation of sample based on the known distribution of the country population by sex and age. We select the numbers using RDD. Numbers are randomly generated using information from National Telephone System. And in RaMPS, we only use mobile phone service so far in the process. So the periodicity, this is one of the key aspects of RaMPS that I think it's very useful. It's rapid, but at the same time allows country to quickly run a survey and adapt it per its needs. So if a country is passing a legislation in tobacco, alcohol, or health diet, can produce this data quickly to support and guide decision-making process. Next, please, Karen. So regarding to implementation, so it's really driven by countries' need. Countries identify which is what is the area that they need to gather information, what is the purpose this data will be used for. We do have some ethical aspects that we follow. We follow the WHO guidelines on ethical issues in public health surveillance. Since RaMPS is a surveillance tool, we submit this, for instance, here in PAHO to our PAHO ERC for their review and response in terms of human subject research, if it is a human subject research, and then from RaMPS specifically for the round that we have run, we receive the exemption from ethics review. So the interviewer training, we follow what the most common procedures. So we have standard data collection procedure, and we have data quality assurance protocols to assure that we follow a standardized and quality procedures during data collection, not different from other surveys that we have, right? And the data collection period was something that I see very valuable, as I mentioned before. In the experience we had in the first phase of this initiative, where we support the implementation in 5 countries, the time on the field was for 4 weeks and from 4 to 6 weeks. Next, please. So we do have a better a guideline presenting all this information more in depth that we can assess later. We have also included in our Enlace data portal the fact sheets for the countries, where we can look later and explore and learn a little bit more about the results from this first phase. And as I mentioned, the first phase, we did have a lot of interest in collecting data from COVID, but also we were able to learn a bit about the access to hypertension and diabetes in these countries during the pandemic, and what was the impact on that. So the first round of countries that implemented RaMPS in the region was Antigua and Barbuda, Belize, Bolivia, Honduras, and Paraguay. So the questionnaire was a questionnaire that had questions on attitudes and behavior related to COVID. We have demographic questions, risk behaviors and protections towards COVID, risk communication, vaccine receptivity, and then the impact of COVID on the services. So service disruption. So the sample size cannot be less than 2,000 from our piloting and testing that we have done, because we are interested also to get information on diabetes. And as you know, the prevalence of diabetes is among in the region, an average, it's 80%. So the length of the questionnaire, the interview, was around 12 minutes, and the countries, which help us to have more cooperation from the participants. Next, please, Carlo. So here, I just thought it would be useful to share with you some of the data gathered during this first phase. So of course, we are all interested to understand the impact of COVID on the income, on the population income, how they perceive this impact. And then you see on Bolivia, Honduras, Belize, Paraguay, Antigua and Barbuda, the countries that we collected this information during the pandemic, there was a high impact on their income. They have reported that they were really affected by the pandemic, as we all know. It was a confirmation of the perception that we all had, right? Next, please. We also had questions that asked about the most trusted source of information to change behavior related to COVID. So here you see all these different sources, which is Minister of Health, PAHO, WHO, Friends, religions community, independent medical society. So the majority of the population were going to seek information at the Minister of Health and the PAHO WHO. So this is was the main source of information, but was really interesting to know, if you look into the yellow one, there's a proportion of the population that was really not interested to seek information to change their behavior. This is a question related to COVID, but we can use this type of questions to learn more about health diet and so many other policies that we have on NCDs, to see what are the source that people are using to really learn how to improve their behavior, change their behavior. Next, please. We also had a question on the media source. So here you see social media was really a key media source for information during COVID. And so television. We have done exercise disaggregating by age, and then you see how interesting it is when you look the oldest population are still seeking TV, and social media is more among the youngest ones. It's a way that we see how we could target the information and the products that we develop to raise awareness in the population. We saw, for instance, I had expectation on the use of WhatsApp, which we know is very a common media source in Latin America, for instance, to see how WhatsApp was playing a role, but you see that some of the population were using, but it's not like broad as we expect. Next, please. Here's the questions that we had in terms for service disruption. Really want to know in the population how they were affected. So we asked what was the percent to produce the estimate of the percentage of the population that were diagnosed with hypertension and diabetes, and it's pretty similar to what we are seeing in our household surveys. Of course, here it's referred. We're not able to measure, but it's pretty similar and close to what we see in the household surveys where we are measuring the population. So we could be higher, I would say, but it's pretty close. We also asked if they were using medication, but what was very worrisome was to see that there is a big proportion in the population that had to stop their medication during the pandemic. So they were affected on their treatment because they were not able to have the medication and keep their treatment. This happened, as you can see, pretty similar in Belize, Bolivia, and Honduras, where 20%, around 20% of their population had to stop their medication for hypertension. More concern we have as well with diabetes in these countries, where a big part of the population had also to stop to take their medication for diabetes. Interesting to see that in Antigua and Barbuda, it seems that we had a better response there. So the population were able, the percentage of the population that had to stop was not like expressive as we see in Belize, Bolivia, and Honduras, and Paraguay. And we have a colleague that will present detailed information on Paraguay, so I don't want to spoil nothing, but we see the response in terms of hypertension was better than the response for diabetes. Next, Caro. So this is information. It's just to illustrate the kind of information we can have to push and assess what the policies and interventions that we are implementing. So specifically for public health crisis, the data that I just showed make the case that NCD should be part of the emergency response for any type of emergency response, because it does affect those that are living with NCDs highly. And finally, I just want to finish this presentation talking about what we see as innovation in this tool. We think that we need to close the gap and have information on the effects of the policies and interventions in our population. And this will help us to break barriers, improve our response, our effectiveness in response, and accelerate perhaps the implementation of this policy. For instance, if we want to learn more about flavored products in tobacco, this could be a tool that we could gather information in the population to see what is their perception in terms of this type of products, for instance. So finally, we see RaMPS as a complementary tool on our NCD toolbox. We think it's really, it's a tool that it's flexible, it's rapid. We really can do it in a short period of time. We can have daily timely. If you have a legislative, you are in a legislative process and you need to gather in the data in the population to sustain any decision or to push for a policy, we can really run the survey in a quickly way, and has this two potential. Can produce data to promote the implementation of policies, so or a front of package of labeling for nutrition. If we ask the population if they have seen, without having the octagonal, for instance, implemented, if they read what is in the packages and ask if that helped them to make decisions, and later on ask if it's helping them to make decisions, maybe would help us to push more to implement front of package labeling in our countries. It's just an example of the use of this information. We also see in mobile phone surveys in general a lot of potential for other activities that we would want to see happen. One is the frame. When we build the frame for mobile phone surveys, we are working with an implicit frame. Perhaps having the data when we do our STEP surveys, our national health surveys, our census that is happening now, when we have the information from this households with mobile phone surveys, perhaps would help us to select better, to do a more, let's say, comprehensive process of selection. And also, when we are doing our STEP surveys, we are seeking in the future to perhaps collect the mobile phone survey from this respondent, so we could follow up in the future with this participant. So that's the thoughts and the strategy that we have developed that I want to share with you. Later on, my colleague Dolores will talk about the phase 2 of the project. Thank you very much. I'll stop here. Thank you.
Excellent presentation. Thank you, Dr. Caixeta, for providing that overview of the methodology for the rapid mobile phone surveys on NCD policies, but also showcasing how valuable it is to use such a tool. I mean, she presented data from 5 countries. It was implemented during a pandemic. It yielded some fascinating results, like the disruptions in access to medication, where a quarter of the population were affected in some countries. So again, an extraordinary tool that can provide timely and rapid data on NCDs. So thank you, Dr. Caixeta. And now we're going to move over to talk about how phone surveys in general are mode for data collection. And we have Dr. Veronica Lee, who is the team lead on surveillance and information systems at the Centers for Disease Prevention and Control. Dr. Lee, over to you.
Thanks, Silvana. So, hello, everyone. My name is Veronica Lee. I'm an epidemiologist in the Office of Global Non-Communicable Diseases in the Center for Global Health at the Center for Disease Control and Prevention. And it's my pleasure to speak with you all today. Our team has had the opportunity to provide technical support to ministries of health to conduct mobile phone surveys on NCDs and COVID-19 since 2015. As part of our work with Bloomberg Philanthropies Data for Health initiative, and then most recently with the RaMPS surveys. So I'll be presenting today on all of the available modes of data collection for mobile surveys in general, and then share some of our experiences talking about the pros and cons for each of the modes. So I'll start with an explanation of data collection modes and methods of administration before discussing the mobile phone survey modes in a bit more detail. So modes are simply the method of survey data collection. For face-to-face or household surveys, the typical modes for collecting data include paper and pencil and CAPI, or computer-assisted in-person interviewing, where the interviewer reads the questionnaire from a device like a tablet and then records the answers electronically throughout the process. Now, for mobile phone surveys, current modes of data collection include Caddy, or computer-assisted telephone interviewing or call center, as what's done in RaMPS, interactive voice response, or IVR, SMS text messages, and then online mobile web. And so within the mobile phone survey modes, there are really two methods of administration: interviewer administered and self-administered. So Caddy, as it used in RaMPS, is distinctive because a live interviewer is present during the interviewer. Caddy contrasts with IVR, SMS, and mobile web because these three modes are self-administered by the respondent. For these modes, there's no interviewer, and these are anonymous data collection. So our team has had the opportunity to work with country partners on population-based surveys using all four types of these data collection modes. And of course, all have pros and cons. So I'll start with IVR, or interactive voice response surveys. These are where respondents listen to a pre-recorded question and then they self-report their responses by pressing numbers on a telephone keypad. IVR is useful to reach populations with low literacy levels because it requires no reading by the respondent. IVR uses very basic mobile phone technology to connect with respondents. So any phone that can receive a phone call can be used by a respondent to participate in an IVR survey. And the accessibility of affordable basic technology is key in this survey mode because it allows for IVR surveys to reach people across many socioeconomic groups. And this is really one of this mode's main benefits. IVR is a cost-effective mode, but typically these surveys have a longer turnaround time from survey planning to completion. And some users are not as likely to participate in this mode because of the lack of engagement with a live interviewer. So for this reason, when using this mode, the questionnaire needs to be concise and clear. Moving on to SMS surveys. These are self-administered and self-guided surveys where questions are sent to respondents one message at a time, and they collect data via structured text messages. This is an accessible mode because it also, again, uses basic mobile text message phone technology to connect with respondents. And depending on how the survey is designed, text messaging rates may apply to participants, but it's considered an affordable mode for data collection. SMS is pretty popular in populations where a higher percentage has access to a mobile phone rather than to the internet. And it's also useful in areas with unreliable connectivity, since it doesn't require respondents to have internet connections. And messages can be received even when the phone is powered off or out of range when that initial message is sent. It's useful because respondents can take the surveys when they are available. However, the target population must be literate since the questions are pre-programmed text with static answer responses. Also, these questionnaires must be very short and questions need to be concise, since individual messages are limited to 160 characters in length. Now, lastly, of the automated or self-administered modes is mobile web. And mobile web is essentially an online-based survey that can be administered on a basic mobile phone browser. Respondents receive an invitation through an SMS and then are redirected to a web page to complete the self-administered survey. And the advantages of this mode as a survey really surround the capabilities. Advanced question types can be used in mobile web questionnaires. Mobile web surveys are not limited to character counts per question, like SMS surveys. The capability to include photos and videos in a mobile web survey can also be beneficial because these forms of media give options for explanations and examples to the respondents. Mobile web survey costing is generally lower since the SMS messages are only used to recruit participation in the survey. Each of the SMS messages used to recruit the respondent may or may not have a cost, but once the respondent opts in to these types of surveys, there is no cost at a per question basis. This mode does, though, require respondents have internet connectivity, access to a web browser, and or a data plan. So lastly, I'll talk about Caddy. Telephone surveys using the Caddy mode, these use interactive computer systems to assist the live interviewers to administer the surveys. These are administered through call centers to conduct live person-to-person interviews using structured scripts. And again, this is the mode used in the RaMPS surveys. Caddy questionnaires are advantageous for several reasons. They can be longer than IVR and SMS and mobile web surveys, and the questions don't need to be as concise. Answers can be open-ended, and the interviewers can probe for respondents. Caddy can be used for populations with low literacy rates, and interviewers are available to help clarify or explain questions. Importantly, Caddy surveys usually have higher response rates than the self-administered modes, and we have seen this in the surveys that we have been involved in. Caddy surveys do, though, require that interviewers in call centers are trained on the questionnaire as well as the survey processes. And there may be higher costs associated with this, but the COVID-19 pandemic has really opened the opportunity for many more local providers. So the costs for call centers have really decreased since the pandemic. So listed here are a summary of some of the strengths and the weaknesses of the four main types of the mobile phone survey modes that I've described. And understanding these can be really useful when determining the appropriate mode for data collection in a mobile survey, just in general. So I've described each of the modes that can be used for mobile phone surveys. So I'll end just with some general points that are important to consider when selecting the mode for a mobile survey. Mobile phone penetration rate, as was mentioned previously. This is the percentage of the population that has access to a mobile phone. To participate in a mobile survey, you must have access to a phone. So of course, this is really an essential factor, as increase in accessibility to the population will lower coverage bias. And in a mobile survey, we aim to minimize the coverage bias. So that's where a sample isn't representative because part of a population doesn't have a chance to be included in the sample. So the higher the mobile phone penetration rate, the closer that mobile phone population is going to approximate the general population, and the better the quality of the data. Literacy rate is also an important consideration. Populations with low literacy rates are best suited for those verbal or the spoken modes. So this would include Caddy as well as IVR. And then the target population is of course crucial when selecting a mode for a mobile survey. We need to consider that access to a mobile phone may differ by categories such as age, gender, and/or education, and some modes may be better at reaching certain segments of the population. For example, a mobile web may be more accessible to a younger and an educated population, whereas older both males and females may be easier to reach through a Caddy survey. So with regard to questionnaire content, shorter questionnaires are better suited to those self-administered modes, IVR, SMS, mobile web. And this is to reduce interview fatigue and break off. And these modes are also useful, IVR, SMS, and mobile web, when asking very sensitive questions, since they may have less social desirability bias. However, questions with open-ended responses or questions that may require clarification or explanation are really best suited for that Caddy mode. Now, costing is always a factor for consideration. And in general, SMS, mobile web, and now really Caddy are among the most cost-effective modes for mobile data collection. It's very important to clarify to the respondents if they will incur airtime or data charges to participate in the survey, and surveys taken at no cost and where respondents are compensated for participation, they generally have higher completion rates. And we've definitely seen this in the self-administered surveys that we've worked with countries to field. And then lastly, the level of broadband internet access and smartphone penetration is another factor that can guide mode selection. Respondents with basic mobile phones can't participate in those web surveys, for example. And high smartphone penetration is really going to increase the modes that are available for data collection. So thank you for your attention and for the opportunity to talk to you about the different modes available for mobile phone surveys. And I look forward to continuing the discussion.
Dr. Lee, thank you so much for talking about all the different ways there are to collect data on NCDs and on health in general, and for pointing out some of the pros and cons of each of the different modes and some of the factors that ultimately will influence the decision around which one is the right one. And as you note, the mobile phone surveys are an excellent, innovative new approach, but there are some drawbacks and some considerations to keep in mind in doing those. And we're going to continue the conversation around using mobile phone surveys and now talk about how it can be used to assess socioeconomic measures. And for this, we have Dr. Talip Kilic, who is a senior economist from the Living Standards Measurement Study at the World Bank. So Dr. Kilic, please talk to us about phone surveys.
Excellent. Can you hear me okay?
Yes.
Okay, perfect. So thank you so much for the PAHO team for having me. Thanks again, Roberta, for the invitation. As mentioned, my name is Talip Kilic. I'm with the World Bank Living Standard Measurement Study Household Survey Program. And today I'd like to talk to you about our work on informing country-level monitoring and policymaking through phone surveys, technical assistance, and impact monitoring now for the past 2+ years. As mentioned earlier in the call, with pandemic-related disruptions to face-to-face surveys, there has been a surge in phone surveys to help fill data gaps, particularly in low and middle-income countries. Since April of 2020, our program has led several initiatives related to phone surveys. We led working groups within the World Bank to rapidly develop survey guidance and tools to operationalize phone survey systems in 100 countries, and often basically starting from a point where phone surveys had not been implemented before by national statistical offices. Second, we channeled funding and remote technical assistance to monthly phone surveys in 7 African countries that have been conducted by national statistical offices, and these surveys in the first phase of the program amounted to close to 70 survey rounds with 130,000 interviews, basically from April 2020 to up to November 2021. And these phone survey data, I also saw some questions on the chat. On our end, they are documented and publicly available and can be accessed through the World Bank Data Library. And we're planning an additional 6 survey rounds per country to be implemented basically between now and through 2023. And some of you may have already seen this, but our experience with the first phase of the program, basically as of the August of last year, roughly about a year ago, was published in a food policy article. And this is also an open access, which I encourage you to check out. And we present an overview of options for phone survey design and implementation, and provide recommendations for phone and mixed mode surveys to be a mainstay in low and middle income countries, not only during the pandemic period, but post-pandemic as well. So across these surveys, there are several innovations that I'd like to highlight. First of all, the LSMS supported phone surveys have relied on pre-COVID-19 household surveys that were nationally representative, that were longitudinal household surveys that served as sampling frames for phone numbers. And the pre-COVID-19 survey data were used to counteract coverage as well as non-response biases that are common in phone surveys. And that information is actually informing the recalibrated sampling weights that counteract these biases. And we've also demonstrated the utility of pre-COVID-19 survey data for bias adjustment for both household and individual level analyses. And there are 2 specific publications that we put out that I also encourage you to check out. And these same households that had been visited as part of the phone surveys in these, in these African countries that we've supported are due to be visited in upcoming face-to-face surveys, enabling again a more comprehensive analysis of the COVID-19 impacts. And the second area of innovation has been in the scope of the information that we've collected. And as the pandemic unfolded and the policy priorities basically evolved, we designed and implemented specialized survey modules to respond to changing data needs, including on labor mobility, economic sentiments, vaccine hesitancy, and uptake, to name a few. So in parallel with our support to these phone surveys, we've also implemented several activities to monitor and strengthen NSO technical capacity since the start of the pandemic. First, in partnership with the UNSD and Paris 21, we've implemented 4 rounds of the global COVID-19 survey of NSOs to monitor NSO operations and needs. Under the aegis of Intersecretariat Working Group on Household Surveys, we released a technical guidance note on planning and implementing face-to-face surveys under COVID-19, released a technical note on remote technical assistance for surveys, and disseminated guidelines and survey tools for designing and implementing phone surveys. And finally, in terms of the training of the national statistical offices and other counterparts at country and regional level, we provided hands-on training to African NSOs that are the implementing agencies of the phone surveys in these 7 countries, and designed and conducted a remote training course on phone surveys, training again 120 some trainers across 7 regions. And the resources that are again on the slide, including the tools associated with the remote training course, are all free and hyperlinked for future reference. So finally, we paired the phone survey data that have been collected in these countries with the pre-COVID-19 face-to-face survey data collected from the same households for rigorous monitoring of the responses to and impacts of the pandemic in several domains. On labor impacts, we've seen that a significant share of women, significant share of workers lost their jobs following the onset of the pandemic, and that women were significantly more likely to lose their job vis-a-vis men. But a year later, these inequalities appear to have disappeared. On income losses, we've seen that across Ethiopia, Malawi, Nigeria, and Uganda, 256 million individuals about 77% of the population were living in households that suffered some degree of income loss at the onset of the pandemic. And the households with income from non-farm enterprises were in fact the most likely to report an income loss, also over the longer term. On food insecurity, we've documented that over 105 million adults were affected by moderate or severe food insecurity across these 4 countries, plus Burkina Faso at the onset of the pandemic. But over the longer run, again, the food security impacts have gradually declined across these countries as of, again, last August. And finally, on vaccines, the COVID-19 vaccine acceptance rates have remained high in countries with these high-frequency phone surveys, with at least 4 in 5 people willing to be vaccinated, all but in one country. And here I've sort of tried to sample some of these highlights from the various publications that we put out over the last 2 years or so. And again, you can also access them on our website. So some thoughts for discussion, for our consideration. We've seen, obviously, as also emphasized by the previous participants, phone surveys have been feasible and useful during the pandemic. But the continued use of phone surveys for routine and crisis monitoring in low and middle income countries in particular have several requirements. First, we've sort of drawn attention to the need to collect phone numbers more systematically in future face-to-face surveys, such that the sampling from these surveys can reduce bias in subsequent phone survey rounds. Second, countries and international agencies must sustain investments in NSO, IT infrastructure, and human capital to ensure sustainable use of mixed mode surveys in the future. Third, there's, I think it can still continuing scope for further developing, but also consolidating guidance on phone survey tools and protocols. And finally, it will be beneficial to accelerate methodological research to improve phone survey design, implementation, and use. And I think here there are several strands of research that could be pursued, particularly in these contexts where phone survey applications are relatively new, including module placement, survey mode, behavioral or respondent effects, and these can be gauged through randomized survey experiments. In general, there's significant scope for enhancing tools for paradata analysis for data quality control. Many of these surveys, again, are implemented on software platforms that provide such paradata, and this is also a topic of importance even for the face-to-face surveys that are implemented on the basis of CAPI. And finally, we could also think more critically about integrated use of face-to-face and phone survey data sources with alternative data, including web surveys and other social media data that, again, could bring about benefits that would be only possible through data integration. So with that, thank you again very much for the invitation and your attention.
Excellent. Thank you very much, Dr. Kilic. And those are really insightful experiences from the World Bank on using mobile phone surveys to assess the impact from a socioeconomic perspective that COVID has had. And I like how you validated that mobile phone surveys are an acceptable and feasible approach to replace perhaps the household surveys that are more traditional. And I also really appreciate that you've highlighted the importance and need to help build capacity around mobile phone survey implementation design to ensure quality So thank you. Thank you for sharing those thoughtful remarks. I just want to point out to everybody that we do have simultaneous translation, English, Spanish, and Portuguese. It's in the little icon below under interpretation. And this is especially relevant now because our next presenter is going to speak in Portuguese. We are really fortunate to have with us Dr. Ellen Posetti Gouveia. She is from Brazil, from the Vigitel program, and she's going to talk about how in Brazil they've applied this very innovative survey approach to monitor NCD surveillance. Over to you, Dr. Ellen.
Boa tarde a todos. Tudo ok, Silvana? Me ouve?
Everybody can hear me. Good afternoon. Yes.
Ok. Meu nome é Ellen.
My name is Ellen Posetti Gouveia. I am the General Coordinator for the NCDs surveillance in the Ministry of Health. I work with the Health Surveillance Secretariat. So I'll talk to you about Vigitel, which is a method we use in Brazil since 2006, and it also uses the telephone to collect data. Vigitel has as its main goal monitor the risk factors and protection factors related to chronic NCDs. This survey is an interview with people, adults that are 18 years old and older in 26 state capitals in Brazil, as well as the federal district. We use a landline. We haven't adopted cell phones yet. This will be done this year. And actually, I think we are beginning that today. This survey is carried out by the Ministry of Health in a partnership with the phone operators. Up to 2020, we had a partnership with the biggest companies in Brazil in order to carry this out. And in the past 2 years, Anatel, which is the National Telecommunications Agency in Brazil, has been working with us. They share with us the phone numbers so that the health ministry can make the calls and can interview the population. And besides this partnership, we have a partnership with the universities that offer us the technical and scientific support so that the country can carry out this research with all the bases we need. And we also have PAHO and its office in Brazil that has been helping us to carry out Vigitel every year. We have never had an interruption since 2006 when it was started. We have had 16 editions for this survey in the country. We had the first interviews in 2006, and that continued until 2021. We have more than 784,000 interviews carried out in these 16 years. And we have more than 50 indicators that are monitored by the survey. The main indicators are those related to prevention and risk factors related to NCDs and chronic NCDs, such as use of alcohol, tobacco, the existence of chronic diseases, preventive measures for cancer, among others. And during some moments, we also used indicators to monitor the pharmaceutical assistance offered by the Ministry of Health to the population. Behavior in traffic was also monitored, and we also try to monitor some seasonalities. For example, sometimes we had factors related to dengue, the flu, and now COVID-19. Besides the reports, the regular reports that are published every year, there are some reports that have certain themes and that were published throughout these years. Working with the National Health Agency, we published reports that include data from other areas. In 2016 and 2018, we have had a specific publication for the population of African descent in the country. And we also had in 2018 another specific report to cover the behavior in traffic. In 2020 and 2021, we updated the reports. So besides the regular report that is published with indicators on the protection and risk factors related to chronic NCDs, we also published 5 thematic reports. These reports showed the trends for the indicators throughout the 16 years. So we have the morbidity related to chronic diseases and health assessment. We also have one about diet, physical activity, and tobacco and alcohol consumption. Those were themes, and there are separate reports for these themes. So they were published besides the year report because they show the trends of the factors in the Brazilian population from 2006 and 2021, which is the most recent year report. The Vigitel questionnaire keeps the same structure since 2006. These indicators are being monitored, and we want to follow the trends for these indicators throughout the years. However, some items were added throughout the years and some were removed when we noticed that something wasn't being used. The Ministry of Health and the scientific team, the researchers in the country, considered that some questions should be eliminated in order to keep the questionnaire short and effective. And we have an interview that lasts about 12 minutes nowadays. And here are some characteristics. We have questions about social and demographic information. We have a self-assessment of the diet. We also have physical activities, use of tobacco and alcohol. We have a self-evaluation of the health status, cancer prevention, mobility, and behavior in traffic. And we also included recently questions about COVID-19. And every year, this questionnaire is assessed. So every year before the questionnaire is used in a new phase, in a new round of interviews, this questionnaire is studied and analyzed. The technicians and researchers in the field and from other areas of the Ministry of Health take a look at it. This goes beyond the regular team that works with it. And we do this so that the questionnaire can be relevant and so that it can represent the country, and also so that we can maintain a history of the indicators we're interested in. Data collected. The data are used to support the public policies in the country. The data is used to monitor, for example, the National Plan for Strategic Actions for the Notifiable Diseases and the NCDs. We monitor the goals and indicators that are part of the NCD plan for the country. We also monitor tobacco use data. And we also monitor international indicators, for example, the global PAN for the chronic NCDs. And besides monitoring chronic NCDs, we also use the data for the implementation of public policies, such as the diet policy, the National Health Plan. Vigitel is aligned with several policies that the country has, such as the oncology policies, and other health policies. The data are also used by researchers in the country. There are different kinds of publications that use them. And this is a collaboration, an attempt to implement policies and to change this outlook for the NCDs in the country. Besides the reports that are published every year, last year, for example, 2021 was a year in which Brazil noticed some difference in the Vigitel data. So we published the data on this platform that is on the screen. This is accessible to citizens, and we wanted the data to be free so that all the health managers could have access to this and could then use the data to support their public policies. This platform exists to make it easy to see the information so that the information can be used to improve planning and implementation of public policies, which includes regulation, interventions, and other actions. So among the indicators we have in the platform are mortality, birth rates, and last year, Vigitel was included there too, so that people can check the Vigitel data. This platform is very user-friendly. The user can choose the 40 indicators that are available and then can select the year. You might want results from a specific year, for example, and then the tool will show you several views. You can view it in different ways. There's a table view, for example. You can have a graphic view. We have a CSV file in this case, and researchers can download these files and use the information in order to support their work with this information. You can go ahead with the slides. The data is disaggregated by sex, age, and area in the country. We have data from all the state capitals. And I just wanted to show you what this platform is like and the kind of views you can have in order to see the data. The health managers that don't understand maybe epidemiology or statistics very well, they can still use this here and visualize the numbers. So we have obesity here on screen, and then we can see age, education level, sex. We can separate the data based on these categories. And the user can view the indicator by year, and the user can also access the trends for the indicators. You can see if a certain number is going up or down, and you can view here on the screen, we have sex, for example. And then we have different perspectives. We would like to increase the mobile aspect of it. And as I explained in 2022, in the edition for this year, we will start interviews with cell phones as well. And one of the challenges for the country is to compare these indicators that come from the landlines, compare these with the cell phone interviews. We want to broaden the representation, and we want to go beyond the state capitals too. So in 2023, we would like these surveys to represent Brazil, including the state capitals, but also other areas. And also we want to keep the partnership we have with Anatel, the National Telecommunications Agency. It was a great success. The work we did with them, we were able to improve the surveys with their help. And we also want to continue working with the Supplementary Health National Agency, ANS, because we want to increase the representation of the population in the country. We still work with the universities, especially with the Federal University of Minas Gerais, UFMG. We have planned a study for data collection using the omnichannel strategy. We want to have several communication channels so that we can have a closer relationship with different areas. We want more information on risk factors related to chronic NCDs, and we want to do this in a way that really mirrors the Brazilian population. So we want to have offline and online represented. And besides this study, we want to update the projections for these indicators based on the 2022 census that is being carried out this year in the country. We had a census in 2010 with data from that year. So now the IBG, the statistics agency in the country, is carrying out the census, and we can have updated information, and we want to have a better indicator for race, for example, with the new data from the census. We want to improve the views, the view modes that we have and that I showed you. The platform is available to everybody who wants to access it, but we want to have an analytical dashboard for the data. We already have a partnership with the Heart Hospital in São Paulo, and we want the user to be able to view the indicators they want, create graphics, download data in a more user-friendly way. We want the data to be extremely transparent. And working with Vital Strategies and Zenesis, the Health Secretariat is also creating this other platform, Harmony, to share data that have to do with morbidity and mortality. And we want data to be very accessible in a user-friendly way, in a way that can be easily used, so that the managers, the universities can use the data, and so that they can have qualified and high quality information so that they can work on the country's health. The data on the platform and the micro data are available for download on the Ministry of Health website. And all these reports through these 16 years of the Vigitel editions are also publicly available, and everybody can have access to them. Thank you very much. Thank you so much for this opportunity to show a little bit of this survey that is very important for our country.
Thank you to you, Dr. Ellen. That was excellent. And we're always so impressed and motivated after listening to people like you from the Ministry of Health of Brazil brag about and talk about the successes of Vigitel, because really Vigitel is a model for amazing NCD surveillance, all the data that's generated, the way in which it's disseminated, the way in which it's made publicly available, the way in which the data is used to monitor nationally, regionally, and globally all of the indicators we have on NCDs. So thank you so much for your commitment to NCD surveillance, to all the great work, to you and the entire team in the Ministry of Health of Brazil for keeping the Vigitel system going and succeeding so much. Thank you, Dr. Ellen. So we're going to move now to Paraguay and hear a little bit about the experience in Paraguay in implementing the RaMPS rapid mobile phone surveys on NCDs. So I'd like to invite Dr. Rodrigo Burgos, who is from the NCD Surveillance Director in the Ministry of Health of Paraguay. And he's going to talk about the experiences and results of RaMPS in Paraguay. Over to you, Dr. Rodrigo.
Thank you so much, Silvana. You're very kind. I am going to share my screen, and I will try to start immediately since we don't have much time. Yes, we hear you very well. Yes, your presentation is visible. Thank you. I am going to present the case of Paraguay on RaMPS. We are most grateful to PAHO for the opportunity to implement this strategy in Paraguay. As it has already been said at the beginning of this meeting, I would like to say that these RaMPS surveys on ENTs and on the repercussions of COVID-19 during the pandemic, we have tried to measure the knowledge, the attitude, and practices related to this disease and the influence that it may or may not have had during the COVID-19 pandemic. We are most grateful to the CDC and for RTI International, since they helped us in the telephone central. We work with people that are older than 18 years old, that have access to a mobile phone. As Roberta described, we did not use home phones, and we had a sample of 2,000 interviews or surveys. The International Telecommunication Union says that there is a penetration of 98% of mobile phone in the population of Paraguay, and we use these RaMPS instead of a call center with a randomized dialer. And these surveys, or the script of the surveys, was prepared by the technical team of the surveillance team, and we try to turn the language more colloquial, better adapted to our language, and we try to standardize the options for the education level, and this was updated according to the survey that is being carried out by the PAHO right now. So we try to do this so that the data would be easier to compare in the future. The national sample, we did not have a sample for the ideal phone number, so we took the phone numbers from the companies that work in our country, the national ones and the international ones. This sample, according to the census office, was more or less the proportion of the age groups that we used, and also of groups according to gender, about 30% each. And also, depending on the market, we spoke about 25% for each of the main mobile phone companies that operate in Paraguay, so that each line would have the same possibility of participating. With regard to the highlighted results for this surveys, first of all, we can say that the survey took place last year between September and October. It took about 5 weeks of work in the field. The company that was in charge of the survey was the ICA Consultoría, using the platform Survey to Go. RTI International provided the list of phone numbers to the enterprise. 7 surveyors were trained in order to replicate situations which they could have to live through this survey in the field. The average duration of the survey was of about 8 minutes, and it was possible to obtain about 2,000 replies. And for this result, we had 13,000 attempts to interview. So this has to do with the methodology and the use of time and resources of the surveyors in order to arrive at the final results. 83% were in the urban areas of the country. About 40% had higher level education, that is to say they had finished high school or above, and the majority of survey people were women. This usually happens in mobile and in virtual surveys or in household surveys. As far as the age groups, about 30% belong to each age group. What did strike us was that in the central department, where the capital of the country is, there was a participation of 41%, and the next one was Alto Paraná, which is the most cosmopolitan region of the country because it has a triple border with Argentina and Brazil, and the third one was Itapúa. So what really has impressed us was that the capital of the country, which is the most populated city of the country, and we suspect that they really rejected this survey due to the activities that take place in the capital. So when we look at the questions related to COVID and where we try to find out which preventative measures were taken by the surveyed people, the majority spoke about using masks outside their homes. We have to take into account that in September and October last year, there was more flexibility with the restrictions, and the situation was coming back to a relative flexibility. It was different from the beginning of the pandemics. When Roberta described at the beginning, we see that about 60% did not visualize that this had impact on their work. Nevertheless, in the same proportions, people did see a reduction in their income. So I suspect that people did not lose their jobs, but they did maintain their job with a shorter contract, different contract, or with lower pay, or they were not permanent jobs.
And when we see, and this is something we can highlight clearly, the most reliable source of information, we see that the people at the time stated that they trusted their information from the Ministry of Health, which is a challenge also, since they have to become the opinion leaders in the field of health. And they did speak of the channel most used was the television, which means that this mass media is not abandoning the Ministry of Health when reporting or informing the people. Then the second level, or the second place, was by the social networks, which is probably most used by the young people. When we speak of access to services, as I described before, it's quite relative to speak here of a prevalence because of the possible bias that could exist when asking about this type of a phenomena. We could say, however, that between 5 and 7% of the people stating they had hypertension had no access to the medication during this period, or had no access to the services to pick up their medication. It's a little higher in the case of diabetes. And here, though we did not ask for the reason why they were unable to pick up their medication, We suspect that it could be due to the restricted movement or due to a limitation of the disease itself, or maybe even the scarcity of these in some of the services. And the other question, which was the mental health, which is what we're talking about today, which would be probably the greatest impact of the restriction measures or the uncertainty itself of the COVID-19 phenomenon, we found that about 30% did consult the mental health services during this time, during the pandemic. And now to close, we could say that most of the people surveyed were women from the urban area, from the highest educational level. The use of masks was probably the most common behavior outside the home. Most of those surveyed said they had no impact at work, which was what we were saying. However, they did see a decrease in their income. The surveyed also use the Ministry of Health as their main source of information, and television continues to be their main channel of information. We see that less than 10% of those surveyed were forced to interrupt their drug treatment for hypertension, and less than 20% of those surveyed did so for diabetes. And 1 out of every 3 surveyed stated that they had to go to mental health services. And as a conclusion of our experience, we could say that the RaMPS in the case of Paraguay was an efficient method of a relatively low cost to collect data from the general population in a timely manner, as the colleague said at the beginning, complementing the more traditional surveillance strategies like the household surveys or population surveys. The other thing is that depending on the phenomenon and the context, one can maximize these advantages of the implementation of RaMPS, especially in the middle and low-income countries. And lastly, bearing in mind the resources we have for surveillance, RaMPS could become a valid complementary tool with the obvious limitations that the colleague from the CDC mentioned into the conventional surveys for non-communicable diseases. And I invite you to visit Paraguay. We would love to have you there, and we're very grateful for this opportunity, and hopefully I can answer any question you may have. Thank you very much. Thank you, Dr. Burgos. And congratulations for the excellent job of implementing RaMPS in Paraguay. The results were very interesting, and we see that it is a feasible methodology. Hopefully, we'll be able to continue working with the health ministry in Paraguay to extend the use of this new tool. We have reviewed all the RaMPS history, the background, the experiences in the region with the mobile surveys, and now we're going to the future to see how we can increase the use of RaMPS in the region from the point of view of PAHO. I'd like to invite Dr. Dolores Ondarzuhu, the technical officer of NCD Data Analytics here in PAHO, from our non-communicable disease surveillance team. Dolores, you have the floor. Thank you very much, Silvana.
To English for the presentation. Okay. Okay. Well, hello, everyone. I would like to share with you where we are with the implementation of the second phase of RaMPS in the region. So for the second phase of this initiative, we have built on the experiences from the first phase conducted in 2020 and 2021. And we are now working with St. Lucia, with Suriname, and with Uruguay. We are currently on the preparatory stage before data collection, working with local partners in the programming and the testing of the questionnaires that are included in the platforms for data collection, and training of interviewers and data collection will start shortly in the 3 countries. So as you can see in this slide, each country has developed a survey instrument according to their data needs. So while some topics are shared by all countries, such as questions on nutrition, each of the countries has identified priority areas that they wish to get data for. For example, St. Lucia added specific questions about mental health. Uruguay included questions on alcohol and COVID-19, and both St. Lucia and Suriname are measuring the awareness of physical activity campaigns and walkability. And then once data collection is finalized, we will work on data validation, weighting, and analysis. And of course, results will be available at the Enlace or Inlace data portal. So a key aspect of this initiative is its flexibility and its ability to gather data on attitudes, behaviors related to the implementation of different policies and interventions. So I would like to share with you the example of Uruguay's questionnaire to illustrate some of the topics that can be included in a RaMPS. As you can see, the Ministry of Health of Uruguay has identified 5 key areas to cover in their instrument. These are nutrition, tobacco, alcohol, access to health services, and COVID-19. So many of the items included in Uruguay's questionnaire will provide information on the NCD Best Buys and other recommended cost-effective interventions for NCDs. And regarding nutrition, for example, as you can see, since Uruguay has front-of-package warning labels on food and beverage products, they are interested in knowing the impact that these labels have on the population's purchase behavior, how aware they are of the nutrition facts, what's the people's attitude towards a possible ban on the sale of foods with warning labels in schools. We also want to know more about the frequency of consumption of sugar-sweetened beverages and how an increase of prices in these beverages would impact on behavior. So for tobacco, for example, we will get to know about people's perception of the health risks of electronic cigarettes compared to manufactured cigarettes, and also about exposure to secondhand smoke. For alcohol, we are interested in getting information on alcohol advertising and promotion, and we are also asking about people's attitude towards an increase of alcohol taxes. We will also be able to get data on the diagnosis and treatment of hypertension, of diabetes, and of other diseases, and on how the pandemic has disrupted health services and treatment. And there is also interest in asking about the access of population to telemedicine. And finally, there are some questions on COVID-19, similar to the ones that we saw results for phase 1, mainly about risk communication and the population's attitudes towards vaccination. So all of these topics are covered by a short set of specific questions in Uruguay's questionnaire. So I would like to end my very short presentation with some highlights. It has already been said that rapid mobile phone surveys produce timely data to assess policies and interventions, and they do so by gathering data on the attitudes, knowledge, and behaviors of the population on topics related with NCD risk factors. This way, we will get valuable data, not only to assess, but also to support the implementation of interventions, such as those which require the enactment of regulatory policies, for example, front-of-package labeling for food products, tobacco control interventions, bans on alcohol advertising, and we can also produce information on access and quality of healthcare. RaMPS are flexible, they are adapted to changing needs, and survey instruments are designed based on each of the country's needs and also on the local policy context. And finally, I would like to remind you that as we continue scaling up this initiative, we provide technical cooperation at PAHO on the preparation, the implementation, and the data analysis of RaMPS to respond to the region's information needs. So with that, I led my presentation, and thank you very much for your attention.
Great. Thank you. Thank you so much, Dolores. And just to once again call attention to the fact that all of the data and information that we're collecting, that we've done in the previous 5 countries, that we're going to do in these new 3 countries, are all going to be disseminated on the PAHO website through the Enlace NCD data portal. And how to access it, you can just go into Google and type in PAHO Enlace. Enlace is ENLACE. And there you'll find all the data that we've collected on NCDs, risk factors, mortality, NCD policies, including the RaMPS information and RaMPS data. So I realize we're a little bit over time, and I apologize for that, but there's so much really great information to talk about and experiences to talk about. And, you know, I promised at the beginning of this session that we wanted this to be interactive, encouraged a lot of questions and comments. And I see that there are over 30 questions and comments. So thank you to everybody. So we're going to pass over now to Carolina Chavez, who's from our NCD program here at PAHO in the surveillance team. And she's going to manage the session on Q&A, and then we'll close up. And we thank everybody for their patience as we run a little over time, especially the interpreters. Over to you, Carolina.
Thank you, Silvana. Thank you, everybody. I'm going to switch into Spanish, if you don't mind. So, gracias a todos por las preguntas y los comentarios que hemos recibido en la
Thank you very much to all for the questions and comments that you have sent us through the Q&A section. As we said, the material will be available for consultation. PAHO will provide technical assistance to implement these surveys in the countries according to country needs and the subjects of interest. I would like to discuss some specific questions about methodology. The comment has been made that RaMPS does not replace household surveys. It is a complementary tool for the surveillance of NCDs. Somebody asked, how can the RaMPS, how could they be integrated to the household surveys such as STEPS or census specifically? And would the panelists be kind enough to reply to that question? Thank you. Dolores, perhaps you would like to reply. Caro, I'm going to start. I will talk a little bit about the methodology. There were questions about how reliable is the information that is collected. So we are using a selection process for the surveyed people based on probabilistic systems. And also we have data collection processes which are based on best practices. We have also tried to compare some indicators which were obtained through RaMPS and compare them with household surveys. For instance, the population that has been diagnosed with hypertension. A survey will never get exactly the same value of another survey that has different methodologies. But for instance, one of the strategies in Brazil is to look more at the trend than to anything else and to see what the trend is. So the idea is to obtain the information that is reliable and trustworthy in order to support policies and interventions. We have seen some questions about the questionnaires. For instance, in the work surveys, we have groups of questions which have taken place throughout the years, and we have that included in the questions about policies. And along the same lines, we developed for COVID, something that Dolores has already mentioned. RaMPS is an important tool for those who are on advocacy. I saw a question that it really helps to drive policies, and it is very welcome to have a support from the civil society in order to drive policies. I believe those were some of the points that I wanted to point out. I do not know whether Veronica wanted to add something, or Ellen.
Thanks, Roberta. I think you've covered well. I would say that for RaMPS and for the mobile surveys, as with any data collection, we know that good training and good processes are going to help ensure that the data that we collect is the best possible data. As you mentioned, a lot of work is done to also contextualize the information. That starts with developing the sample size and the age and sex quotas to match the population for the country. So looking at that, we get a good sense of how the data align to the country. And then, as you mentioned, where data are available, contextualizing that information. So, thanks.
We see your hands up. Can you?
Yeah. I just wanted to just open a parenthesis in this discussion. I think, I mean, in terms of the classes of phone surveys that we've been discussing in this particular seminar, I think there's quite a bit of market difference in terms of efforts that rely on random digit dialing versus, say, the types of surveys that we've implemented that have used existing household surveys as sampling frames for phone numbers. So I think in the context of the former group of surveys that have relied on RDDs, some of these strategies that Veronica has mentioned are fairly common practices, but to the extent that, I mean, we can only be, I guess, sure of what we're matching in terms of population totals, only in terms of the extent of the variables that we use for that calibration purpose. So if there are certain underlying issues regarding the selection and the representativeness of the sample, the RDD methodology in and of itself may not cater to those biases. And in certain contexts, those biases, the direction of the bias is also not known. So I think as we think about different classes of surveys, phone surveys, in this specific class that have relied on household surveys as sampling frames, right, for phone numbers, there is some additional bit of calibration that we could do that I think analytically gives us a bit more, perhaps a bit more of a scope for how exactly we can calibrate the sampling weights to ensure representativeness, precisely because in the context of face-to-face surveys that could provide phone numbers, we would have information on non-responders, as well as information on people that do not have cell phone, do not have access to cell phone to begin with. So, and I think those access issues are particularly pronounced in settings where there are kind of marked gender differences in access to and ownership of mobile phones as well. And to the extent that we're collecting individual level information, those gender differences underlying cell phone use and ownership could also be considerable. So I'm just mentioning these things because I guess the extent to which we can cater to the selection bias, right, associated with the phone surveys has a lot to do with the utility of the resulting data sets. So if we can also think about settings, contexts in which RDD-based phone surveys could be implemented in parallel with phone surveys that use household surveys as sampling frames, this kind of comparative assessment could be undertaken, right? As part of I mean, it could even be kind of an integrated survey experiment where we can really get at these issues around, okay, to what extent we should still be worried about selection bias for phone surveys that rely on different approaches to sampling design. Okay, over to you.
Yeah, we consider on the RDD when, I mean, we are doing the weightings on the process to make the adjustment, the process stratification, but I think the RDD are the challenge that maybe RDD present, and in the sense is clear in the fact that it represents the ones that have access to the mobile phone service. So we are linked to the limitation of what the survey is. But as I mentioned, I would love to see and seek a way where we can have a panel survey, for instance, in health, where we can follow up and build the frame from that. But one of the challenges, the struggle that I was reviewing the literature is to really being able to have a good frame. So I think my point is that we will face bias and limitation in different aspects in each one of the surveys, because the numbers and what people are using the moment that we collect the information for that mobile phone that belongs to that particular household might change throughout the time. This is one of the challenges that I've seen that might affect the process of building a framework from a household survey. But in that same, and I'm saying this because I would love to see if we could do, let's say, steps and later on track progress with this people that we have identified in the household that have some particular conditions, hypertension, diabetes, that we can track throughout the time, and this might not become feasible because we see people change numbers, mobile phones are not active. I do understand it might diminish the number of inactive, let's say, phones that we have, but it still raises concern. But I think it's a valid point, and I would love to test that like in using panels with steps in the future. Thank you. Dolores.
Thank you. Just to add to this discussion and to address some of the questions in the chat, actually there was a question about how RaMPS work in relation to step surveys, and this was actually from the colleague in St. Martin, who a country we are working with in the planning of a step survey. So just like you were mentioning, there is some potential to think about how a step survey could work as a sampling frame, or at least to see how that works. So I think it would be a discussion that we could have in the future. But what I want to highlight is that, because there were some comments about this, that this is, again, a complementary tool, a supplement to the other surveys. There's no intention to replace any of those, but it's more about getting a different type of information, more related to policies and interventions. So it's a different objective compared to those household surveys. Mm-hmm. And I just wanted to add as well, based on a question, that we are working with different languages as well for sub-countries. So there was a question about the diversity and how inclusive the survey is in that sense. So for example, for Suriname, we are working on developing questionnaires not only in English, but also in Dutch and in Sranan Tonga. So we can work quite easily to address that as well. Thank you, over.
So other question that I've seen here is about the training. If it's a protocol that only PAHO people can train. No, we want to have the methodology available for anyone use. And if you need any support from our side, we are happy to contribute and discuss and talk about. Regarding to funds, as we mentioned in the beginning, for these rounds, we were grateful to have resources coming from CDC, the Public Health Agency in Canada, and also for Universal Health Coverage project. So this helped a lot during this phase, at least to develop the methodology, pilot, implement in several countries. This was a way that allowed us to move forward with this. Unfortunately, as you all know, resources are limited and NCD in general, and we sometimes struggle to really provide funds for the implementation phase. But as we can, we have been able to support implementation of RaMPS in a couple of countries.
And just in terms of time, maybe we can start wrapping up. I think that the last set of question, or one of the concerns that were raised also, is about the confidentiality in the surveys, how to ensure the confidentiality through the ethical committees that we were commented in the presentations. But some countries might be concerned about the raise of all the false calls by telephone, so people are not confident to answer this survey. So what's the experience in the telephone surveys to answer this? So if any, Veronica, please, thank you.
Sure, I'm happy to provide just some brief comments about this. And I think, thanks for raising the question. So in terms, as you mentioned, Carolina, all of the surveys have ethical approval. And the first question in the survey is where the respondent consents to the survey. So very similar to when to any other type of data collection. The first question is to obtain a respondent's consent to participate. A couple of key points is that the data are not linked to a respondent's mobile phone number. So that's key. Respondents are given a unique identifier, and their mobile phone number and their data are not linked. So the data are de-identified. Also, in terms of just a general combating potential distrust around a new mode of data collection, I think there are several avenues that we have taken. One is to do some education within ministries of health to understand, and as the COVID-19 pandemic has changed the way data are collected, many countries are becoming more adept and open to non-traditional modes of data collection. So one is to do some sensitization within ministries of health around this type of data collection. Understanding that not to let the perfect be the enemy of the good. Mobile phone surveys can provide a good source of information and understanding, and helping ministries of health understand where they can be used. And then lastly, we have had some success with very lightweight media campaigns. So this is posting on ministries of health, Facebook, WhatsApp, things like that, to sensitize the population that the surveys are ongoing. Over to you. Thanks.
Thank you, Veronica. And well, in terms of time, I will pass then the presentation and the closing up to Silvana. Just quickly to mention that I will post in the chat the email from NMH Surveillance. So we are happy to answer any other question by email. Thank you.
Thank you. And thank you to all the panelists for this rich discussion. This is the best part of any webinar, right? When we get to hear and hear the questions from the audience and exchange ideas and get into more of the details. And of course, we'd love to keep going on and on, but being mindful of time, we're going to close the session. We hope you've learned a lot. We hope we've inspired you to collect more data on NCD policies and interventions at the population level and convinced you that mobile phone surveys are a valid and feasible approach, not to replace step surveys, for example, but as a complement, another tool within the NCD surveillance toolkit. And from PAHO, we're here to support all the ministries of health and assist and disseminate all the data as well. So you can count on our support. And I just want to thank you for your participation and staying with us for the full 2 hours. We had about 250 people from across the region, and we're really pleased with this level of commitment to NCD surveillance and improving NCD surveillance. I want to thank all the panelists for sharing their insights, their experiences, and being part of this. I especially want to thank the PAHO NCD surveillance team, Dr. Roberta Caixeta, Dr. Dolores Andarsuhu, Dr. Carolina Chavez, our administrative team, Jilka Teles, Jenny Elizabeth Vallejo, Sonia Ortiz for organizing the webinar. And I especially want to thank our interpreters for allowing us to speak in English, Spanish, and Portuguese. So thank you to everyone and have a great day, and be on the lookout for more webinars from PAHO on NCD surveillance. Thank you. Have a good day. Bye.